Thank you very much. It's good to be here in South Africa, and we were given a special treat a couple of hours ago that came about as a result of the meeting I gave in the youth group yesterday afternoon. I happened to mention there about the difference in critical thinking. We were talking about IQ and EQ, and I mentioned how it doesn't take critical thinking to drive an automobile. Otherwise, we wouldn't let 16-year-olds do it. But if things go wrong and you're in instrument conditions in an airplane, it does require critical thinking. And I gave the example of the Air France pilots who didn't recognize what instruments were going bad and which ones were still accurate, and ended up doing a stall all the way down to the Atlantic Ocean, and lives were lost. And mentioned how if you have alcohol in the last 2 weeks, that can make the difference. Well, what I didn't realize was that we had a pilot from the South African Airlines that was present at that meeting. And he runs a flight school about 40 kilometers from here. And so he proceeded to ask me to see if I wanted to take an aerial tour of this area. And he brought over his little gyrocopter that I had never flown. It's kind of a cross between an airplane and a helicopter. So we were able to get some good views of the camp, and then we went and chased some animals out in the wild with that thing. And of course, it's all out in the open, and so I was able to see zebras and impalas and animals' names I can't even pronounce, who were running from us with great speed to try to stay in front of us. Except there was a zebra in the middle of all this pack who would just stand still and look at the other animals running like, "What are you afraid of?" But did indeed have an enjoyable time with that. Today we're going to be talking about the brain and some things that can go wrong with the brain. Indeed, this organ does have weighs just 2.5 pounds, 1 kilogram, but yet the details of the human brain are pretty astounding. It is the most complicated structure ever investigated by science. That means it's more complex than the most complex computer. It means it's more complex than even the space shuttle. And I don't know how many of you have been to Kennedy Space Center to see all of what is involved in a space shuttle launch, but it's even more impressive to go to the Houston Space Center, which is called the Johnson Space Center, because that's where all the controls are at. When the astronauts say Houston, that's who they're talking to. And you can see, over 100 individuals monitoring different things on that space shuttle when it's in flight, where they can communicate with the space shuttle itself. Many different computer systems analyzing all sorts of things. And as complex as that is, your human brain is actually more complex. 100 billion nerve cells. You would not even be able to count all of your nerve cells if that's all you did from the time you're born until the time you die. If you went through and tried to count them all, your life would be over with long before you got to 100 billion. There are even more supporting cells known as glia. We used to think the glia were just nutritional support, structural support cells. We now know that they're also involved in thought processes. And then when you consider the different types of cells in the brain, as complex as the liver is, as complex as the heart is, when we categorize the cells, there's only cells in the 20s, 24 different types of categories of cells in the liver, about 22 in the heart. And those are very complex organs. We can't live without either one of those for very long. But the brain, what sets it apart is there's thousands of different categories of cells, even thousands of different types of neurons. So that makes the brain even more complex. If we were to take a look at the schematic of a neuron, which you can see overhead, the dendrite is where there's receptor areas to send an electrical signal down that axon, and at those terminal buttons there are chemicals released. And if there's nerves next to them that can receive those chemicals, part of what's called neurotransmission, then another electrical signal occurs. And this is how communication occurs in the brain. This is the area under a schematic microscope the synapse, those chemicals being released and then received on the receptor nerve. Now, speaking of the synapse, a regular neuron will make 1,000 connections with other neurons. So one neuron will have about 1,000 synapses. And the Purkinje cell that's diagrammed there will make 200,000 connections. This is a big player in the brain. One Purkinje cell influencing 200,000 other nerves. And if we were to add up all of the connections in the human brain, the conservative estimate is 100 trillion connections in this 2.5-pound brain. And actually, recent estimates state that it's probably 10 times as many more as that. So that makes even the American national debt seem like a small number in comparison to how many connections you have in your own brain. And of course, the pharmaceutical industry is trying to influence those connections. They're giving you chemicals to try to influence that synapse and maybe make more serotonin available, or maybe more dopamine, or more norepinephrine. But every time there's a drug that's utilized, there's also unintended consequences sometimes that result from that. Well, in the book Mind, Character, and Personality, Ellen White says to deal with minds is the greatest work ever committed to men. Quite a statement, isn't it? To deal with minds. And all of us have that opportunity when we're in a family environment, when we're in an educational environment, when we're in a work environment. We have social connections. We can also have the work of, or being part of the work of the greatest work ever committed to man, and that is to deal with the minds around us. Now, one of the things that can go wrong, whenever you have something that complex as the human brain, you need to realize that there are things that can go wrong with complex systems. I think it was mentioned the other day that I'm an instrument-rated pilot. I fly quite a bit in the U.S. In all sorts of conditions, instrument-rated, and I have to get there on time. We don't fly through thunderstorms or tornadoes, but we'll fly through just about everything else. It's surprising how many times, with all the flights I've taken, even the big airplanes, how many times things can go wrong with those airplanes that delay the flight, or it's even canceled. And hopefully it's not in a foreign country. I know I was in Rio de Janeiro, Brazil, where the flight, there was mechanical problems, and there weren't the right mechanics in Rio to be able to fix the problem. So we had to spend another couple of days in Rio de Janeiro until you could have someone actually fix the mechanical problem. And so there's always things that go wrong with complex systems. How many of you have had a computer and have used that computer a lot and never had anything go wrong with that computer? Okay, I don't see any hands go up. That means that we even have honest Macintosh users here today, because often Macintosh users will try to state that nothing ever goes wrong with their computer. But I have a Mac, and I realize that things can even go wrong with a Mac computer. But if there's things that can go wrong with the computer, there's obviously things that can go wrong with the human brain. And one of the things that goes wrong with it in increasing frequency is major depression, as well as anxiety. In fact, there are more things going wrong with the human brain in this generation than there have been in previous generations. The number of people developing depression worldwide has steadily increased since 1915. And this is using the same definition of depression. So every successive generation, we've had more of it. Major episodes of depression now occur frequently by age 25. When I was growing up in the 1960s and someone began to suffer from this, I wasn't part of a medical family, but I would ask my family, what's going wrong with Mrs. McPherson? And they would tell me she's suffering from a midlife crisis. That was the term that was used for major depression back when I was growing up. We don't use that term much anymore because frequently episodes of depression are occurring in the teenage years, even adulthood. We've had, in early adulthood. And we've had many individuals that we've treated through the years. I'll ask them, when did depression first begin? And they'll be able to tell me exactly how they felt and how they remembered feeling at age 7 or 8. So it can occur at even an earlier age now than before. Overall, the risk of depression has increased over time, however, in all age groups. So it's even more common in the elderly than it used to be. And there are, of course, reasons for this. What studies are showing is, as far as major depression is concerned, which sometimes is called endogenous depression, it seems to come from within. And often the individual doesn't know why they have it, and even their doctor doesn't know why they have it. They just diagnose major depression and they start them on an antidepressant or a medication. But it's a little different than situational depression. Situational depression is due to you losing a job or your spouse leaving you or some bad things happening in your life. You can get depression from that too, but that's situational depression, and it tends to run its course and then get better. Endogenous depression seems to just stay around, and it doesn't necessarily get better with time unless it's treated. But either forms of depression, either the situational or the endogenous, we use this definition. If it's endogenous, you cannot have recently faced obvious emotional trauma. Well, you will still experience at least 5 of 9 symptoms for at least 2 weeks. The first symptom of major depression is deep sadness. Now, there is a psychiatric international Bible. It's called the DSM-5, the Diagnostic Statistical Manual, Volume 5. They just came out with Volume 5 a few months ago. And the Diagnostic Statistical Manual says, yes, deep sadness qualifies, but also emptiness. Some people will not have the sadness, but they'll just have a feeling of emptiness. And that will also qualify as symptom number 1. Now, this tends to often be gender related. Which gender do you think tends to have more of the sadness? It is women. And what symptom do they tend to get when they have this deep sadness that often tips them off? Anyone? The symptom that they have often that tips them off are crying spells. And how they'll explain it to me is they'll say, something happened yesterday. It wasn't that bad, but I didn't expect it to happen, and I didn't want it to happen. I would have preferred it not to happen, but when it happened, all of a sudden I noticed that I was crying. And I was thinking, what's wrong with me? Nobody has died in the family. It's not like things are going terribly wrong. Why am I crying? And then the next day, they'll notice themselves crying over something that they're disappointed in, and that's when they end up coming to the physician and saying, telling the story, and the physician will then ask a few other questions, find out it's depression, and then they go out the door with an antidepressant medicine. Men, however, tend to get the emptiness more so than the sadness, and men will assume that this empty feeling is just a normal part of their existence at that point of their life. It's not normal to feel empty or sad, particularly the majority of the time. And by the way, you don't have to have those symptoms all the time in order to have depression. You just have to have them the majority of the time in the last 2 weeks. And if you have that, that's distinctly abnormal. The second symptom is apathy. Now, apathy is when you wake up in the morning and you're not excited about the day. You wake up in the morning and you get up out of a sense of duty and responsibility, but you don't really have significant interest in the day's activities. Now, once again, that might be normal once in a great while to have that happen, but when that happens the majority of the time, that is distinctly abnormal. And one of the things that happens with individuals with major depression is that they will notice the things that used to be pleasurable for them no longer are pleasurable. And of course, that's where that, I don't know if this song made it to South Africa, but one of the big popular songs was, I Get No Satisfaction. And of course, that's describing the the symptoms of depression, particularly the apathy symptoms. The third symptom is the one that's actually least recognized by people who have it. I'll often ask them in this third symptom, by the way, either you're more irritable than you used to be, so agitation is part of it, or also the psychiatric Bible says if you don't have agitation, but you have slowed down in your muscle movements, you also qualify for symptom number 3. And neither one often is recognized by the individual. And so hopefully there's someone with them at the time I ask them this question. I just will tell you, before I came here, I was in the office with a gentleman. And fortunately, his wife was there, and I said, so, sir, are you more irritable now than you used to be? He said, no, I'm not. And his wife is over there in the corner saying, oh, yes. And I said, you know, your wife is disagreeing with you on that question. And he turns around and says, what do you mean? And she came up with 3 examples just in the last week where he lost his cool, where he didn't used to lose his cool and be that irritable. And so he turns around to me and says, well, she's right. I guess I am more irritable than I used to be. Often when people slow down, they don't notice they've slowed down until they see themselves on a video camera at a family reunion event as they're, replaying this, and they're watching themselves walk over to pick up a ball or something, and they're saying, is that me? I mean, I didn't realize I was moving that slow. I look like I'm depressed or something. The fourth symptom are sleep disturbances. Now, what do you think is the most common sleep disturbance for those with major depression? Anyone? Insomnia. Insomnia is pretty common. This is when it's time to go to sleep, and you lay down, and you can't go to sleep. But that's actually not the most common sleep disturbance. What might be the most common? Sleeping too much or sleeping during the day. We call that hypersomnia. That's pretty common as well. Some depressed people want to sleep virtually all the time. We have people that come to our program every time that are sleeping sometimes 18, 20 hours a day. They're barely awake long enough to be able to survive, to be able to eat enough and stay clean enough in order to actually survive. And of course, that's severe depression. But hypersomnia is still not the most common sleep disorder. What's the most common sleep disorder symptom? All right, someone in the front seat says, sleeping in church. And it's kind of funny, as an internal medicine physician, we deal with a lot of sleep-related issues. And I'll often ask the person when they have trouble sleeping, I can't sleep at all, I says, you go to church, what happens there? That's the time I fall asleep. I'll say, okay, your remedy is you need to buy a pew and install a pew in your bedroom and sit in that pew at night. Actually, I don't tell them that, but sometimes I'm tempted to do so. But no, that's not the most common. The most common is what we call early morning awakening. This is where you go to sleep, but then you get up too early and you can't go back to sleep. So first it'll be like you need to be up at 6 in the morning, you'll be getting up at 4 and can't go back to sleep. But as the depression gets more severe, you might wake up at 2 in the morning and not be able to go back to sleep. Distinctly abnormal. And when that happens the majority of the time, that's a significant finding. The fifth are weight or appetite changes. Now, what's the most common weight or appetite changes with those people with depression? Is it weight gain or weight loss? Weight gain is actually more common than weight loss. Now, why is weight gain more common? It's called self-medicating. Individuals will try to feel better by actually eating certain foods that not only taste good, but actually make them feel better for the short term. What type of foods might those be? All right, I heard it over here. Chocolate is a big one. Chocolate not only tastes good, but it'll actually raise your dopamine levels a little bit. And because it has sugar in it, it'll raise your serotonin levels a little bit, so you'll actually feel less depressed. Now, what happens is when you start utilizing chocolate as a form of self-medicating, your serotonin levels and dopamine levels will actually go down even further than they were between times. And so you have a sense of a need for more. In fact, studies have shown that if you want to do a screening test for depression in your local area, just stand outside your supermarket and watch the cans of soda pop leaving. Those that are on sodas and sweet things, that's often self-medicating for depression that is going on there. Weight loss does occur, but normally it'll occur when the depression is severe and sudden onset. So sudden onset and severity will often produce anorexia and weight loss. And interestingly, in our program, we run programs for people with severe depression and anxiety. About half of the patients that come to our program, a little more than half, have what's called treatment-resistant depression. In other words, they've been through medicine. Often they're on 4 different medicines when they come to us for depression. They've been through counseling. They've even often been referred for what we call shockwave treatments or induced seizures under general anesthesia. And sometimes that's when they'll come to us. The doctor will say, you either need to be permanently disabled or you need to go to shockwave treatments. And then they'll hear about us as an alternative program and come. Or they've been through shockwave treatments even multiple times and still have depression. And then they'll come see us. So that's over half of the group are a very severe group that has basically come to the place where they think their situation is absolutely hopeless. The other less than half group are ones who have become educated on the adverse effects of the medication and don't want to get on medicine. Or, and so they'll either be a group that has never responded to medicine well, even multiple medicines, or a group that just refuses to get on medicine, and so they come looking for an alternative approach. But in regards to weight loss, I'll just tell you, when we have a whole group, because we bring them together, we run a group program, although it's very individualized, as you'll find out as well. So we have a very individualized approach, but then we have some general treatment things that work for anybody with depression. And that's when we utilize the group therapy. But as you might imagine, we have people that look very anorexic that are there, and we have people that are overweight that are there. But the majority of our depressed patients are not necessarily normal weight. We will have some normal weight individuals. We like those. But what we find out during the program is the people that are overweight all lose weight. They're thrilled with that. And the people that are underweight on the same type of diet actually gain a significant amount of weight. So if it's good nutrition for the brain, you'll actually be able to normalize your weight in that process. The last program we just finished with, we had a 16-year-old girl who was 5'4" and weighed 69 pounds. That's about 30 kilograms. And she had been in the hospital just to try to save her life from that not long before she came. She was told, of course, not to exercise at all because they were fearful that she would lose even more weight. And one of the most gratifying things that she had was on the first visit, I said, yes, you are going to exercise. You're going to exercise aerobically 1 hour a day, but you're going to be on good nutrition. You're going to gain weight. And she actually did. She gained about 3 pounds during the first 10 days. And her fitness level went up. And, of course, her depression totally resolved by the end of the program. Now, lack of concentration is the 6th symptom. This tends to be pretty prominent. And what people will notice is that they're having trouble actually remembering what they read at the top of the page when they get to the bottom of the page. And they'll recognize that, they're reading their Sabbath school lesson or they're reading the newspaper, and then they're just not remembering what they read or being able to put it together. And of course, this can affect people academically. So in a college situation, often we'll get the college students when their grades plummet. And then when their grades plummet, their parents will ask them some questions and they'll realize there's some mental health issues, and then they come to our program. But the concentration can get so bad that people can even have a panic attack in regards to what they're supposed to wear for an evening event. And that's when you know it's getting quite severe. But that one tends to be pretty prominent in most individuals with depression. The seventh symptom is when things are getting more severe, and that is when feelings of worthlessness result. And of course, and this will even occur in Christians, but as a Christian, we should recognize that Christ would have died for just one of us. And how much is Christ worth? He's of infinite value. And so the fact that he would have died for just one of us tells us that each one of us is of infinite value to him. And of course, he's the righteous judge. And so we all should have a sense of self-worth. But when that self-worth goes away, it's a problem. As I mentioned on Friday night, when it does go away, often where you have this sense of worthlessness, often it starts out with inflated sense of pride. And this is something that is not intuitive for a lot of individuals, but you never have feelings of worthlessness until you first have a feeling of an inflated sense of self. And although we need to realize each one of us are of infinite value, when we start thinking that we're more valuable than someone next to us, that's when we're set up for emotional problems down the road. And so the eighth symptom is morbid thoughts. Now, what would be the definition of a morbid thought? Suicidal thoughts? Is that a problem in South Africa? Yeah, I noticed it's on your list there as far as some of the leading causes of death. So there are thousands of suicides that take place in this country every year. But that's not the only morbid thought. What would be another definition or another example of a morbid thought? Okay, someone mentions self-harming. Self-harming, actually, and I must mention this. I told you we always have patients with hypersomnia. We almost always have patients with self-harming. We actually had a program a couple of months ago. It was the first program we ever had where none of the 20 participants were cutters or self-mutilators. But self-mutilation is a little different as far as we wouldn't necessarily classify that as a morbid thought. It seems like it is on the surface, and many people think those that cut are doing it maybe for attention, or they're doing it as a form of maybe trying to end their life or something like that. That isn't true. Cutters are not doing it for either one of those reasons. Cutters actually mutilate themselves as a sense of release. When they mutilate themselves and they see the blood flowing, it's almost like taking a Xanax pill. They have a sense of relief. Endorphins are being released in the process, and they're using it as actually a crutch to help their anxiety at that time. And of course, that sets yourself up for an addiction. Things like that you utilize, even Xanax, of course, can be addictive, and then the cutting becomes addictive. When they recognize, hey, that made me feel better, then guess what? The next time they're that anxious, they're going to try to do it again. And so often they come to us with multiple scars, razor blades, and things of that nature. I'll just tell you a story. We had an individual who had been cutting for 15 years, and she came to us. She had scars everywhere. And she came to us, and the first visit she had with me, she said, "Do not do anything about my cutting, because I've been to every psychiatrist and psychologist in our nation." She was not from America. We get people from internationally coming in for this program, so we've treated people from all sorts of countries. And she says, "I've seen all the experts, and they've tried to work with me on this. I am never going to give that up." And of course, we didn't work with her on that at first. We were working with the improvement in mental health. But once she realized that it was an addiction, she became educated. Once she realized that it was an addiction, it had to be treated as such. And what is the best way to overcome an addiction? Yeah, it is total abstinence for life. And then you have to give up the things that are associated with the addiction. So we asked her to make a decision to give up. What do you think she had to give up? Her razor blades. And of course, this was a big crutch for her. And I remember it was quite a time. It was our clinical psychologist that was talking to her, and with trembling hands, she handed that razor blade over. And in the middle of the program, since nutrition is a major part of our program, we teach them how to shop at a regular grocery store. And in the middle of that program, a few days after she had given up her razor blades, guess what she bought without us knowing it? Razor blades. You know, addictions have that way, you know, where like the dog returning to his vomit, so to speak. Fortunately, her husband was a companion with her, so he reported what had happened. And so we had another conversation with her. And with trembling hands, she gave up her razor blade again. But at the end of the program, by the end of the program, actually from that point forward, that program was ran 10 years ago. She has never cut since. And so when we take care of the mental health issues that's causing it, there's not a need for those type of things that come up. But actually, I know that's a long answer to saying self-mutilation as part of morbid thoughts, actually doesn't qualify. So what else would be an example of a morbid thought? Not necessarily fear. Fantasizing about someone else dying would be a morbid thought. And many individuals actually believe their depression is caused by someone else. And often it's someone else that they don't know how to necessarily separate from. It might even be their spouse, it might be their mother, it might be, who knows who. But part of their morbid thoughts is fantasizing about someone else's death. But that's not the most common morbid thought. The actual definition of morbid thought is preoccupation with death or symbols of death. And so you are seeing when people resonate with symbols of death. My wife showed me the other day of a bathing suit line, and the bathing suit line had nothing but skeletons and skulls all over the bathing suits. What is the fashion industry doing? They're capitalizing on the increased frequency of morbid thoughts of people, and when someone wants to buy that and likes it, resonates with it, it's a clear sign of a morbid thought. People are tattooing symbols of death on themselves. They're doing all sorts of things in regards to that. My son, last winter, or the winter before last, it was his birthday. I was going to buy him a snowboard. In the wintertime, we like to go snowboarding and skiing. And he found the right snowboard, and he turned it over, and he says, "Dad, I don't want it." I said, "Why is that?" And he turned it over for me again to look, and there was nothing but a skeleton on the back of that snowboard. And I asked the clerk, I said, "So why is this here?" And the clerk says, "Well, this was designed by a famous snowboarder by the name of," it's not the most famous snowboarder because I would have heard of him, but it was some snowboarder I hadn't heard of. And my own thought when I was realizing that that's how he designed it is, I wonder how many other symptoms of depression that individual has. By the way, speaking of extreme sports, many people actually, instead of seeking a wise, comprehensive program for overcoming depression, many people with severe treatment-resistant depression actually go in to extreme sports thinking that if I die in the process, it's going to be no big deal. And if I don't die, my adrenaline rush will be so high that maybe I'll get over my depression. And of course, that's a dangerous situation to be in, and many of those people actually do lose their life in the process. The ninth symptom of depression is fatigue. This is where it's not the interest part. This is where you run out of energy. And so you just don't have the energy at the end of the day, or maybe you don't even have energy at the beginning of the day. So you don't need all 9 of those symptoms. How many do you need? 5 out of 9, and you have major depression. And if you have 2 out of 9, it's still abnormal. That's called minor depression or subsyndromal depression. And so it's thought to be in the variant of normal to have 1 of those 9, But 2 of those 9 is still significant. It means you're on your way to major depression, and 5 out of those 9 is major depression. Now, depression would be bad enough if it just did those things, but unfortunately, it does a lot more than that. It increases the risk of stroke by 50%. It increases the risk of sudden cardiac death in those who've survived a heart attack by 2.5 times. How well you do after a heart attack has more to do with your mental health than even what heart medicines you're taking. It increases the risk of heart disease in men. It increases the risk of death from cancer in both genders. It increases the risk of death from pneumonia, which is still in the top 10 causes of death here in South Africa. And it also increases the risk of suicide. Now, many people are aware of the association between depression and suicide, but they're not aware of some of the particulars that are involved. Suicide is often an impulsive act. So you have depression, you have feelings of hopelessness, and then something happens where you become more impulsive, and then you do it, or at least attempt to do it. And to illustrate this, one of the ways in which people in San Francisco, one of the most famous ways to commit suicide in San Francisco, California, do any of you know in South Africa how they do it? They jump off the Golden Gate Bridge. You know, it's 400 feet above the water, and it's kind of like hitting concrete when you jump, and there's only a 4-foot fence there, and there's a big highway, you know, lots of cars on either side, and then they have a little place in case you have car trouble to be able to pull over. And so people will pull over and then quickly make that jump. There have actually been 20 people who survived that jump. They actually landed just right, by luck, really, so that they did not die. Now, they ended up going into the intensive care unit. They ended up with broken bones, sometimes lost limbs. The most common problem was that they shrunk by several inches because they had collapsed broken vertebrae. Most of them that landed happened to land on their feet. And so their life significantly worsened as a result of this decision to jump. So an astute psychologist decided to do a study on these 20 people who'd survived the jump. And the first question he asked is, do you wish you would have been successful in committing suicide? What do you think they said? They said no. We are glad that we were not successful. So just to make sure, he asked them a follow-up question. He said, so you realize then you made a mistake by jumping? And they said, big mistake. Yes, we realized we made a mistake. Then his third question was simply this: when did you first realize that you had made a mistake? 2/3 of them said, as soon as my feet had left the bridge. So they're on their way down and they're thinking, uh-oh, this may not have been a good idea. And it illustrates often the impulsivity of the act. Of course, for over 99% of them, it was too late at that point. They were probably having the same feelings, but it was too late at that point. And this is one of the enigma of the pharmaceutical industry, because the pharmaceutical industry makes it very clear that when you put a depressed person on an antidepressant, their impulsivity goes up before their depression gets better. And that's why they all have these big black box warnings. And that is, if you put this patient on this drug, it might tip them over the edge and they might commit suicide. So that makes it pretty difficult. You're wanting to help the person with depression, and so the doctor often just has medicines in their toolbox. And so you give them a medicine that actually increases their likelihood of suicide before the depression gets better. Another problem with the antidepressants is not only do they worsen impulsivity, but they eventually cause an I don't care attitude when the depression does improve. So studies show that if you have depression and you're taking an antidepressant, you're actually more likely to miss work. Why is that? Because if you're not feeling that great, you say, who cares? I don't care. You know, my boss can just handle it some way or another. I'm just not showing up. And then although it can help their depression, they'll find out that even when a loving person dies in their family, they don't feel sad about it. They don't have the ability to cry at the funeral often. And of course, both of those symptoms are very common in those that take antidepressants, and one of the reasons why we need to find better ways of treating the illness. In fact, it's very clear the pharmaceutical industry is finally owning up to this, that medications have their limitations. They only help people significantly about 20% of the time. Now, up to 70% of the time, the pharmaceutical industry will state that it produces some improvement, but they admit that 30% don't improve even the slightest. But out of the 70% that improve, placebo will improve about that many. And so it's not too much different than taking placebo, except for about 20% of the population that seems to do very well. Another problem with medicine is they've only studied them out short term. You know, and we know it doesn't work within the first week or two. That's why they're always doing studies month, 2 months, 3 months. It's been thought that depression is something that takes months to improve. Actually, prior to our research, which I'll be telling you a little bit about, I used to believe that as well. In fact, when we first began to run depression recovery programs, I told everybody there, do not expect to get better within even 3 weeks. We're putting you on this program so that you can continue on this program in your home setting, but remember, it's a 20-week program, and don't gauge yourself until you're 8 or 12 weeks out. That's how long it's going to take. And I was very surprised when I saw everybody getting better within 19 days, and then we started studying it, and everybody was getting better within 10 days. So when you treat it in a comprehensive manner, it won't get better the next day, but it will get better normally starting within a week, and by 10 days it can ramp up pretty significantly. But back to the medicine studies. Studies are showing that if you put a person on placebo or you put them on medicine, the medicine will do better than placebo for the first 3 months, 4 months, 6 months. But then there will be a crossover after 6 months. And by 1 year, the placebo individual is doing significantly better than the one taking the medicine. Dr. Whitaker has studied this out. This has just been research in the last few years where they're looking at the long-term data on antidepressants. And Dr. Whitaker, along with other psychiatrists and one studying this out, are stating that antidepressants really should only be used short-term, because if you utilize them long-term, they will end up causing more of the problem that they were designed to treat because of some of the changes that take place. So once again, one of the reasons why we need to find ways besides these medicines in treating the disease. Now, of course, depression can cause all those deadly side effects, but it can also cause things that will just decrease your quality of life. Headaches are very common in those with depression. In fact, we have many people on narcotics, all sorts of shots for their migraine headaches and other types of headaches, and within 10 days, they won't need another pain medicine for their headaches. If we take care of their mental health issues, often the headaches completely clear up. Osteoporosis, you lose 2 to 4% more bone mineral density per year as a result of depression. When combined with stress, it increases the risk of HIV progressing to AIDS. Not everyone, as you know, with HIV will get AIDS, but if you have a mental health problem, you're much more likely to do it because of suppression of the immune system that helps bring it about. It increases the risk of return to addictive behavior such as drinking. Now, why is that the case? Why do people with depression have an increased risk of going back to an addiction or going to an addiction? It's a form of self-medicating again. They're trying to feel better for the short term, and they're feeling so bad, they say, I just want to feel better, even for a few hours. And so they go back to a previous addiction. And of course, does that help their situation? No, it actually complicates it much more. It becomes even a more severe problem. It increases problems with anger or hostility. So everyone with depression ends up having social complications from their disease. And that means that their marriage is being affected, the raising of their kids is being affected as well. It increases the risk of developing asthma. And so even lung problems can result. It increases the chance that your offspring will suffer depression and physical medical problems. So it not only hurts the individual, it hurts the chances for the offspring as well. And of course, one of the most gratifying things is when we take young mothers into our program, because when they get better, everybody gets better in their family, and they end up turning their family's course in a very positive direction as a result of coming. It increases the rate of decline in physical abilities with age. Whether you end up in a nursing home or not has much more to do with your mental health as you age than your physical health. It increases stress hormones. That means cortisol levels go up, and of course that produces some adverse effects on the brain. It decreases sex hormones. That may or may not be a good thing, depending upon the individual and their situation. But studies show reproductivity does go down with depression. It suppresses the immune system in ways that are mentioned there on the screen, and it also decreases the memory. In fact, rather significantly, the stronger the bouts of depression, the longer those bouts, the more the memory is adversely affected. And that's something that we actually measured in our last program. We're starting to do more studies. We measure a lot of different things, but in this last program, we gave them an extensive memory test when they came in, and an extensive memory test when they left 10 days later. There was a different memory test, so it wasn't any of the same things that they had to remember at all. And significant improvement occurred in the entire group, and so they were very gratified to see their memories starting to come back. Of course, that produces some positive consequences as well. And then the cost of depression. Although this has been in the United States, you can kind of translate this over. I notice right now it's about 10 Rand per dollar, so you could just multiply this by 10 in South Africa on the dollar amounts. But an average person who works with depression will lose 5.6 hours on average of productive work per week. 80% of people with depression are impaired in their daily functioning. They have less ability to concentrate, lower efficiency, less ability to organize their work. They're over twice as likely to take sick days. And as mentioned, the costs of absenteeism are actually more related to taking antidepressant medicine. But in general, you will still be twice as likely to take sick days. And depressed people are 7 times more likely to become unemployed. When there's an economic downturn, the boss will know who is the least productive, and he'll try to cherry pick the least productive workers to lay off at that point. And of course, many of those cases will actually be mental health cases, those that have been functioning with depression. The long-term effects of psychological problems have been studied during childhood. Children were followed for 40 years to determine the effects of illness and psychological problems on their life chances. 7 fewer weeks of work per year, a loss of 35% in lifetime income, and a lifetime loss for each family who has a depressed family member of $300,000. This is significant when you take a look at the lifetime effects of this. The personal loss in that individual is $10,400 per year in income by age 50. And often they don't realize this. They have economic issues. In fact, most of the people that come to our depression program don't have the money to come. So how are they coming? Well, they're coming because others have heard about their program and believe enough in them that they've been able to raise money for this individual. We had one girl that came to our program. I mean, talk about a basket case wreck in anxiety and depression and all sorts of family relationships. She had just separated from a husband who was beating on her and all sorts of issues. She was strung out on Xanax and clonazepam and all these benzos, plus a lot of antidepressant medicines. But the person who believed in her was actually her doctor in Georgia. And her doctor paid for her entire way to come to our depression recovery program. And fortunately, I was able to return him to her. By the way, she was also on narcotics for all sorts of pain medicine, but within 10 days, she was off all of her benzos. She was off her narcotics. Her depression scores no longer existed. And so she didn't have depression or anxiety. And what a dramatic turnaround. She was just absolutely thrilled. She's felt better than she's felt her entire life. And of course, there's still a program that she's going to have to follow in her home setting. But it's often people that have noticed, and of course this doctor has noticed the difference in other people. So when someone else sees someone go through the program and see that type of transformation occurring, then you can see why it's easier to raise money for these individuals to come. But many of these people don't want to be there because they don't think this program is going to help them. Many people with severe depression have been so many places, they think there's no program on the planet that's going to work for them. But someone else does enough to pay their way. But notice, even though the program, I'll just tell you, in the U.S., the program costs $6,000 for 10 days. And of course, it's actually dirt cheap when you consider all the things the individual gets from this, because they're getting well over $1,000 worth of laboratory. They're getting a lot of clinical psychology visits, spiritual psychology visits, all of their hotel stay, their food, the entire hydrotherapy treatment programs, and other types of treatments, the music therapy. All of this is included in this price. And insurances are starting to reimburse for it because they recognize the data that it works. So often they get some reimbursement from insurance. But nonetheless, $6,000, compare that with $10,400 less income per year. And so these individuals all get their $6,000 back, maybe not from an insurance check, but now they're leaving, since they're depression-free and anxiety-free in most cases, and their income or their emotional intelligence is now at the top 25 percentile, they become very desired employees. And I'll tell you that some of those employees that were basket cases in depression, I have hired myself, and they are exceptional employees after this. And so I've always been willing to invest in people who have gone through this program and had success, and they can often make me even more successful by filling a spot that is open in our office or in other ways. But anyways, in this study, the cost for the total group over one's lifetime, $2.1 trillion, which does not include the increased cost of medical care that all of us must assume. It turns out, if you just look at this economic data, and there's a lot of reasons for national debts. But in America, of course, there's a lot of talk on how we spend too much money. We need to tighten the belt. We need to get expenses under control and those sorts of things. It turns out that if depression and anxiety were eliminated from the United States, there would be no debt whatsoever. You say, why is that the case? Think of all of these individuals making $10,400 more per year and less costs on the Medicare and insurance companies and all of the government-sponsored health programs. And that extra $10,400 will result in more tax revenue coming into the government. We wouldn't have to cut expenses at all. We would just have to take care of the mental health issues, and there would be no more debt in our country, despite the fact that we do have holes in certain areas. And so that's something to keep in mind. A lot of times the burden of any country is related to the mental health problems in that country. And if we're able to make a difference in that, we can actually have all ships rise, so to speak, and the entire economy do far better. Years ago, Ellen White was criticized for writing this. This comes from the book Ministry of Healing. There's a chapter there, a great chapter called Mind Cure. But she said this: the condition of the mind affects the health to a far greater degree than many realize. Many of the diseases from which men suffer are the result of what? Mental depression, grief, anxiety, discontent, remorse, guilt, distrust, all tend to break down the life forces and to invite decay and death. She's no longer being criticized for writing those statements because it's been clearly demonstrated that everything that she wrote is actually true there and, of course, other places in regards to mental health. Well, you might wonder how I myself, I just need to let it be known, I think it's been said multiple times in introductions, but I myself am not a psychiatrist. I'm an internal medicine physician, so you might wonder how in the world, internal medicine is, an internal medicine physician is someone who treats internal organ diseases in adults. And we're often the one called in when there's a lot going wrong with the patient. So we do a lot of critical care work, and we try to referee some of the specialists in critical care. The cardiologists will want to dry out the lungs and give a lot of diuretics to someone in bad heart disease, and the kidney doctor will come around and saying, hey, you're getting rid of the kidney function here, we need more fluid. And so they'll try to pour in more fluid, and so the internist is often the referee saying, wait a minute, no, let's take all these organs into perspective and let's run the fine line here and see exactly where things are at. So that's the type of training that I received. And of course, internal medicine physicians also are trained in regards to diagnosis and difficult diagnoses. So I'll just mention that after my residency, I actually taught in an internal medicine residency for a while. And I used to teach my internal medicine residents to learn the common diseases well. I wanted them to know congestive heart failure as good as a cardiologist. Why did I want them to know it that well? Anyone? It's a common problem. They're going to see it just about every day of their lives. If you're going to see something common and you see it every day, you better know it as much as the biggest expert in the nation knows it. And so they would cringe when I would tell them, that's a lot of information. Really, I need to know it that well? Yes, absolutely, you need to know it that well. And furthermore, I want you to know pneumonia as good as a pulmonologist. Why is that? You're going to see pneumonias very frequently. It's a very frequent reason for admission. I told them I wanted to have them learn gastroesophageal reflux disease as good as a gastroenterologist. 50% of the population is going to suffer from gastroesophageal reflux disease. They're going to be in an internal medicine doctor's office. They need to know it that well. And of course, my residents later on, they would all thank me for that. They would have to learn it that well, and then afterwards they were very well thought of by their patients as well as the specialists, because some of those patients would end up in specialist offices, and the specialists would look at what this internal medicine doctor did, and they'd say, he covered the gamut. I have nothing else to offer you. And of course, the patient would be gratified that they have that good a physician. Now, I didn't want them to know Guillain-Barré syndrome as good as a neurologist. Why is that? They might see it once in their life, and when they see it, they'll know it's something vastly wrong, and they'll be able to refer that over. But the common diseases, I wanted them to know well. So after I finished teaching in my residency, my first year in a regular private practice that I started up in Oklahoma, the Nedley Clinic, there was an article that crossed my desk from the American Medical Association, JAMA Internal Medicine it's called now. It was called Archives of Internal Medicine back then. That showed up to 1 in 3 people who see an internal medicine physician as suffering from major depression. And I thought, common disease, do I know this as good as a psychiatrist? Chris are experts at using combinations of high doses of psychiatric drugs to produce effects and side effects and those sorts of things, and to differentiate it from other mental illnesses. And so I learned quite a bit. Of course, I had to go through a lot of that in medical school, so some of it was review, but I was able to fine-tune the aspects of the traditional treatment of depression. But I recognized what was happening in these psychiatrists' offices was something that did not happen in an internal medicine office. These people were diagnosed with depression and anxiety, and they were being sent out the door right away with a prescription. And for an example, internal medicine people deal with swollen feet. And I thought, this is like seeing a patient with swollen feet, diagnosing swollen foot syndrome, and sending them out the door immediately with a diuretic medicine. Now, will a diuretic medicine, something to get rid of fluid, will it help swollen feet? Maybe or maybe not, depending on the cause of the swollen feet. How am I going to be able to help that person with swollen feet and have the highest likelihood of cure? Find the cause of the swollen feet. And how am I going to do that? It's going to require a workup. We're going to have to find out if there's a problem with the veins, if there's a problem with the lymphatics, if there's a problem with the liver or the kidney or the heart. All of those things can cause swollen feet. And if it's a heart problem, is it a muscle problem in the heart? Is it an artery problem? Is it an electrical problem? And so a workup is required to find the precise cause of the problem. And I recognized this wasn't being done. And so I thought, well, maybe it's not being done for a reason. I looked in the psychiatric Bible, and it said, well, we need to rule out some things like thyroid problems. So yeah, some psychiatrists were actually doing a blood test for a thyroid problem if there hadn't been one done to make sure that wasn't the reason for depression. So, but I thought, you know what, I can't just assume that we don't know some of the other causes. Let's look for them. Maybe I'll find 6 or 8 causes that have been described in the medical literature. And I'll just tell you, I began to get depressed myself when I had listed cause number 71 and still wasn't through. The medical literature had it. No one had just put it together before. And when I got to cause 71, I had to analyze what I had done at that point. I don't know why it was, but getting over the number 70 and realizing, hey, I might only be halfway done, I started to analyze it, and I've realized that most of those causes fell into one of 10 categories. And then I realized that it's not just one of those categories that causes depression. The brain is pretty resilient. When I was studying my patients, I noticed that there was usually 4 categories of causes involved before the individual went through depression or anxiety. And that also tells you how wonderfully creative our Creator has been in creating this brain that can withstand all sorts of assaults and not have depression and anxiety. But once you get the 4th category of assault in, that's when you're going to end up going over the edge and suffering from that. So I searched the medical literature, causes, and these, although myriads of causes, well over 100 is what I ended up finding. Yeah, I haven't been to the ABC to know if the book is sold out yet, but Depression: The Way Out goes over those, and it goes into the 10 categories. But mention usually 4 categories or more combined. So let's, as the second half of this presentation is concerned, it may be more than, we might have already gone more than halfway. But I think it's good for you to know the 10 hit categories. That's what we call them, hits or blows to the brain that can bring about depression. The first cause that's mentioned in the medical literature is genetic. Now this is one that is often way overdiagnosed. But I've been in too many offices where the doctor states this: you were born with a genetic flaw. Your mother had depression, your grandmother had depression. You were born with this genetic flaw, so you must take this medicine for the rest of your life to try to correct the chemistry that's been produced by bad genes. Now here's what's false about that statement. Genetics is never enough to cause depression or anxiety by itself. It's a cause. It's one that we need to know about. But remember, how many categories of causes? 4. Genetics is never the sole cause. And this is something that I've even had to teach physicians. A couple of years ago, I was asked to speak in Germany to a whole group of psychiatrists, and there were some psychologists there as well. But Germany was having an entire summit on depression. And I was at a little bit of disadvantage. I must admit, I don't speak German, and I don't even speak Afrikaans, so I can't even understand some German. I was the only non-German speaking presenter that was there, so I had to go through a translator. And I was also the only non-psychiatrist presenter that was there. And the talk that I was giving was called Lifestyle Treatments for Depression. And at first I thought, you know what, I don't even understand their language. I won't show up until it's time for me to speak. But then I thought, well, maybe I ought to be there an hour ahead of time just to get a flavor of this group. And there was a psychiatric geneticist who was going over the 22 different genes that have been discovered that are associated with depression. And after this psychiatric geneticist gave this wonderful lecture on the genetics of depression, how do you think that medical audience responded to that? Doctors tend to respond to genetic discoveries in hoopla fashion. So this individual got a standing ovation. Why do doctors respond in that way? Well, the reason why primarily is this. If we can understand the genetic flaw better, maybe we can design a drug that can help counteract that flaw, and then we can have a cleaner, better way of treating the depression. due to this genetic flaw. So that's the thought behind it, and so that's why they're all excited about it. Well, it was my turn to speak right after this. And of course, I had the opportunity, since I didn't know English and didn't know German, and I wasn't from Germany, of playing dumb. So I played dumb a little bit to start out with. I said, I'd like you to ask some questions, and have you give me some answers before I begin my talk. Is depression going way up in Germany, or is it not going up as far as the incidence is concerned? What do you think they said? They said it's going up. And actually, that's what I asked for. Is it going up or down? And they said up. And then the next question was, is it going way up, or is it just going up a little bit? I said, I'm familiar with the American statistics. I'm not familiar with the German statistics. What do you think they said? It's going way up. I said, the only way we can explain the rapid rise in depression, and it be due to genetics, is if people with major depression are remarkably more reproductive than people without major depression. And of course, they smiled at that because I just told you the statistics, and they were aware of them as well. What happens with reproductivity and depression? It actually goes down. So I told them this, just based on Darwin's theory of evolution alone, we shouldn't have to do anything about depression. It'll be wiped off the planet within a few generations because people with depression are less reproductive. But then I went on to say the reason why it's increasing is because of the non-genetic causes that are increasing in our society today. And many of those can be reversed through lifestyle change. So that was the introduction of the presentation that I gave. The second hit category is developmental. This has to do with how you're raised. And if you were raised with sexual abuse, with significant abuse in the home, that's a developmental hit. And I can tell you, sexual abuse growing up today is far more common than it was a generation or two or three ago. It is on the rampant rise. And we are living in an over-sexed society, and it has its consequences even in a home setting. And of course, I won't go into the stories there, but you can imagine with us seeing the type of level of depression that we've seen a lot of those type of developmental hits. But it may not be sexual abuse. It may be the fact that you grew up with an alcoholic father who was an issue. It may be the fact that you actually didn't grow up with both biological parents. Do you know what percent of people, at least in America, that grow up from the ages of 0 to 18 with both biological parents raising them at the same time? Anyone want to guess what that percent is now? It's 25%. And often what happens when these parents split up is the parents now become competitors for the children. And of course, they know that if they go before a judge and the child is 9 or 10 or 11 and says, I want to live with dad, I don't want to live with mom, what's the judge going to do? Let him live with dad, as long as dad's not a certified, drug addict and in prison a lot. And so they often become competitors, and so they end up trying to be the most popular parent. And of course, is that a good way to raise a kid, is to try to become very popular with that kid? Actually, you might think it is for the short term, but eventually those kids actually have to go out in society. And when their boss tells them, you've got to finish this job, and I want you to finish it by the end of the day, they think their boss is mean and cruel and has all sorts of problems. But in reality, they don't realize that they have not been raised in a responsible manner, and so they end up having all this emotional reactions to nuisances of life that they should have been resisted against by good parents who were competing for them. So often that can be an issue. The third one, and we won't go into all the developmental hits, but let's just cover some of these main characteristics. The third one is what I call lifestyle hits. You have a lifestyle hit if you're not on a regular aerobic exercise program. Exercise works as good as medicine for the depression as well as anxiety, but you have to become fit. It takes some time, but it does actually work better than Zoloft, and the effects of it last longer. And so being fit is important. But also part of lifestyles, if you're not being regularly exposed to daylight, at least an hour a day, if you're not actually breathing fresh air frequently, that also can be a lifestyle hit. The fourth one is actually probably even more common than the first three. This one we tend to see very frequently. It's called the circadian rhythm hit. And we all have a circadian rhythm, but it turns out depressed people tend to have a greater circadian rhythm hit because most of them end up becoming nighttime people. It turns out when you have depression, you will actually feel better when you're a little sleep deprived. You'll feel more socially connected. And this is what's happening in our colleges and universities, is that many of our college students begin their parties at 1 o'clock in the morning. Why do they do that? That was never heard of a generation or two ago. The reason why they do it is sleep deprivation actually makes them feel better, more socially connected, less depressed. The problem is they eventually have to go to sleep. And when they do, how do they wake up? They wake up a complete zombie. They're fatigued, they don't want to get up, all of the symptoms of depression return. And the solution to the circadian rhythm is not to be sleep deprived. The solution is light therapy at about 6 a.m. in the morning, and you might need a medical grade light box if it's wintertime, and then early to bed, early to rise. And we teach them how they can sleep. They think they can't sleep, early to bed, early to rise, they can, and within 7 days, we'll take all of our depressed people, which most of them are nighttime people when they're coming in, but within 7 days, they wake up refreshed, rejuvenated, ready for the day, and they become daytime people, and by 9:30 they're ready to hit the sack and they go to sleep right away. But that's how quickly a person can turn over. Often people that describe themselves as nighttime people, they think it's somehow genetic in them. It's not genetic. Anyone who's a nighttime person actually can become a daytime person, and early to bed, early to rise is what the brain prefers. Addiction. This addiction might be alcohol, it might be tobacco, it might be non-substances. Often it's benzodiazepines or narcotics. We have a lot of people that come on pain medicine routinely or actually addicted to it. By the way, in regards to pain medicine, studies show if you have chronic pain and you are strung out on pain medicine, if you go through a program to get off your pain medicine, even if nothing is done about the source of your pain, you will end up having no more pain than you did on pain medicine. The difference is that your frontal lobe is now enhanced, and so you'll be able to cope better with the pain. Narcotics and pain medicine were given for short-term pain, like having an operation or surgery or in a short-term acute type of accident. But when you use them chronically, you end up building up a tolerance to the point where if you don't get the pain medicine, your pain level severity is much more severe than it would have been had you never been put on the pain medicine. And so what we find out is many people don't need pain medicine at all at the time they leave. But in regards to non-substance addictions, gambling problems have become much more prominent. There's all sorts of sex addictions that are out there. Pornography is one of those addictions that actually does decrease the frontal lobe of the brain significantly. And so there's all sorts of non-substance addictions that could potentially be a source. And no matter what the source of addiction is, if you have one, it's an addiction hit. And if you have, then you would only need 3 other hits before you end up with depression or anxiety. The 6th one is also very overlooked. It's called nutrition hits. I want to speak a little bit more about this in a little bit because it is important. The 7th are toxic causes. It could be arsenic, it could be lead, it could be mercury. By the way, one of the most common sources of arsenic today, anyone know? Chicken. Yeah, chicken and arsenic. It's a major problem. So the white meat eaters often have arsenic toxicity. It's not just water. A lot of people think it's just contaminated water that has it. By the way, if you want to look at a good nutrition source that's also very entertaining, it's about a 5-minute video produced every day, and you'll actually see the peer-reviewed journal is called nutritionfacts.org. Look up arsenic in chicken. There's several videos on that, and they'll go through all of that, that issue. But more common than those is mercury. And we'll talk about that in a little bit. Social or complicated stress or grief. Now, often, as I mentioned, everyone with depression has a social complication, but not everyone has a social cause. We actually give a test, a screening test. It makes my visit a lot more efficient. You take a rather prolonged test to see which hits are active in you. And often people think it's their social life that's causing their problem, and it's not that at all. It's the other things. And once we clear up those other things, the social problems vanish. But if it is a social problem that's causing it, we want to find out about that as well so that we can give the correct counseling. Medical conditions, we mentioned thyroid, lupus, it could be a stroke in the frontal lobe, it could be multiple concussions, head injuries. This is one of the reasons football players and boxers and those sorts of things, the UFC fighters. By the way, this UFC fighting, in America it's taken off, and it's alarming because studies show in any UFC event, 1 out of 3 times, that individual, the event ends because the individual has undergone a head concussion, you know, the person that loses. And head concussions are serious things. And when you have 2 head concussions, your risk of depression for life goes up in a rampant manner. And it's just enough for one hit, but many people are running around with other hits, and then when they get that head trauma, it takes them over the edge. And it is, you do want to protect your head. Don't think it's not an issue in regards to head trauma, because it is. And the 10th hit category are frontal lobe hits. Now, frontal lobe has to do with things related to spirituality, morality, and the will. And are you regularly reading your Bible and actually analyzing Scripture with Scripture? That's a frontal lobe advantage. Are you listening to good music that helps the frontal lobe? Or are you immersed in Facebook and entertainment television, which actually entertainment television actually is a threat to the frontal lobe? Or are you listening to heavy metal music? And so it has to do with entertainment type issues and what you're doing with your free time a lot that is either enhancing your frontal lobe or suppressing your frontal lobe. One of the interesting studies on light, 96 patients were randomized to receive light therapy plus a placebo capsule or placebo light therapy plus Prozac, which is a standard antidepressant, for 8 weeks. Notice the clinical response rate in each group was 67%. So light alone works as good as antidepressants. But further analysis indicated that light therapy provided a quicker initial improvement. In regards to nutrition, omega-3 is crucial. Many people are not on development, is simply due to the fact that it had a drug-like effect. You needed far less of the bipolar medicines and their side effects, and the omega-3 was able to help both the depression part and the mania part. And by the way, someone actually did develop a drug utilizing omega-3. If you try to develop a drug and you submit it to a patent office, and it's omega-3, and it's been out there in nature, the government will send you a nice letter back saying, sorry, you don't get a patent, prior art. In other words, it's already been there in nature, you're not allowed to patent it. But one company found out a way to patent omega-3, and they patented a mercury removal process from fish oil. It's a 3-step mercury removal process. By the way, don't ever believe there is mercury-free fish oil. There is no such thing in our society because mercury is tightly bound to fish. Some of the supplements will say mercury-free fish because it's not regulated, but if the government were regulating it, they would not allow them to say it. And even this company, by the way, the prescription drug is called Loveza in the United States. You might have it here in South Africa as well. It's very expensive, but it removes about problems that are going to result. Connection between eating fish and body mercury levels is so strong now that researchers seeking to determine mercury exposures among groups of people often look at only one dietary factor, fish consumption. Well, fortunately, you can get omega-3 from more than just plants of the waters. You can get them from land plants as well. Almonds have omega-3. Spinach is high in omega-3. Green soybeans, called edamame, is even higher yet. Soybean oil has it. Wheat germ oil, if you're eating white bread, you're not getting omega-3. Black walnuts have omega-3. English walnuts have even more. Chia seeds is one of the highest source of omega-3 that you can find. And the highest, most concentrated source is actually flaxseed. 1 tablespoon, 7,526 milligrams of omega-3. Another issue that is very common in people with depression is high cholesterol. Patients with major depressive disorder tend to have significantly higher cholesterol levels than healthy adults. Major depressed patients with elevated cholesterol have also a poorer prognosis for treatment response. So that's why we always measure their lipids. Bringing down the cholesterol will help their mental health. It also helps their blood circulation. And a lot of people are confused about cholesterol. They don't realize there is absolutely zero in fruits, grains, nuts, and vegetables. They don't realize also that dairy has some, even skim milk has 4 to 5 milligrams, 2% milk, 18 milligrams, whole milk 33. The only exception to the animal product rule is egg whites that have no cholesterol, but mayonnaise 8, ice cream 29, butter 31. And notice the egg yolk, 213 milligrams of cholesterol. A lot of people are not aware of this. And they're also not aware of this. They think tuna is part of the plant kingdom and has no cholesterol. Tuna is a fish. Even though it's a clean fish, it has cholesterol, it has a liver, it does make cholesterol, and studies show if you put a plant-based vegetarian on fish, their cholesterols invariably go up. Clams, 57, crab, 64. And a lot of people are confused about this. If you scrape the skin and the fat off the chicken, you'll have 73 milligrams per serving, 76 milligrams for pork, 80 for beef, but if you don't scrape the fat and the skin off the chicken, 82 milligrams. More cholesterol in chicken than in red meat, unless you scrape the fat and the skin off, and even then you're not really helping it out a whole lot. And then watch out for the seafood. I have people in America who tell me they're on a seafood diet, and I'll ask them, what does that mean? And they'll say, I see food and I eat it. But often they don't have to tell me that. I can tell by looking at them that that's what's happening. But nonetheless, sardines, 120 milligrams, shrimp, 165 milligrams, kidney, 329. The organ meats are loaded with cholesterol. Liver, 410. Caviar, 500 milligrams. And if you see anyone feasting on beef brains, you have to wonder about their intentions. 1 3-ounce serving, 1,697 milligrams of cholesterol. Now we know cholesterol in the diet is not good, but what we didn't know when these statistics came out on how much cholesterol was in certain foods was that some cholesterol in foods is actually more harmful than others. And how this was first discovered was by a group of medical students in New York. They had to publish a study, and so they fed rabbits and monkeys pure cholesterol for a few weeks to see what would happen to their arteries. And within a few weeks, they all began to plug off. They began to get strokes, heart attacks, even before the study was completed. And they came to the cholesterol researcher and said, we came to you to get cholesterol, and this is what's happened. And he said, cholesterol is bad, but it shouldn't have been that bad. And he started thinking about the cholesterol he had given him. The bucket was pure cholesterol, but it had had its lid off. It had been exposed to the air, and it had become discolored. And he thought, I wonder if it was the oxidized cholesterol causing the problem. So then he fed pure cholesterol that had never been exposed to the air to rabbits and monkeys. And he found out oxidized cholesterol fed to rabbits and monkeys actually produces dramatic vascular damage within 24 hours. Pure non-oxidized cholesterol produced no vascular damage. The pure cholesterol is actually a clear, waxy substance. Then he went the next step, and he said, all right, let's just feed food to the monkeys. So he fed them this oxidized it. And the most commonly consumed custard in America, I don't know what it is here in South Africa, but the most commonly consumed custard in America, can anyone guess what it might be? Ice cream, that's right. Good old-fashioned ice cream. And fortunately, there are ice creams available now that have no cholesterol. If there's no cholesterol, you don't have to worry about them being oxidized. And there's all sorts of, there's Soy Dreams, there's Tofruity, there's Rice Dream. But one of our board members of Weimar Institute, who's a food manufacturer, recently produced an ice cream that actually is the best ice cream I've ever eaten. In fact, anyone who eats it says this is the best tasting ice cream, better than dairy ice cream. And he actually made it out of a base of oatmeal. It's an oatmeal-based ice cream, has 32 flavors. And when I first tasted it, I said, boy, what are you going to name this? He says, you know, the problem is we can't call it ice cream legally because it has to have cow's milk in it to have that statement there. So a few days later, he called me up and he says, I woke up in the middle of the night and I thought of the name. We can't say it's ice cream. And so that's what it's called. We can't say it's ice cream. It is selling very well in America, and hopefully you can get a manufacturer over for it here as well, because oatmeal has some other positive advantages. The second worst was pancake mix. What's pancake mix made out of primarily? Powdering the eggs. And the third most damaging was Parmesan cheese. This is where you powder cheese up. You're heavily oxidizing it. And it actually was tied with lard. That's not a misprint. Both of them were tied for the third worst type of cholesterol. But actually, his study actually explained something else. I should say this. Some mothers, the way they eat, you know, they're eating at McDonald's, fast food places, saturated fat cholesterol. They have more cholesterol in their human breast milk than what cows have in their milk. And there was a study done a few years prior to Bruce Taylor's study showing that some infants begin to get the fatty streaks of atherosclerosis in infancy. Which infants do you think tend to get it? Those consuming cow's milk or those consuming human breast milk? Most of you are saying cow's milk. Why might that be the case if the cow's milk is lower in cholesterol? Well, you're actually right. The human breast milk, those consuming human breast milk had no vascular damage. And the reason why is the way babies consume human breast milk is how? Directly from the nipple. It's not exposed to the air. The cholesterol is not oxidized. So the best way for you to drink your cow's milk would be go down to the barn and get it straight. Interesting, years ago, Ellen White was also ahead of her time. This is the book Ministry of Healing. Especially harmful, she said, are the what? Custards and puddings in which milk, eggs, and sugar are the chief ingredients. The free use of milk and sugar together should be what? Avoided. Then it's now well established that one of the main characteristics of virtually all depressed individuals, no matter what the underlying cause, is a significant decrease in the frontal lobe's blood flow and activity. This is a PET scan. It's like Doppler weather radar. You can see the depressed individual has a depressed brain. Not a lot of activity there. But this is the same brain after they've recovered from depression. Notice the biggest before and after difference is in the frontal lobe of the brain. And this is why our program is comprehensive and deals with the spiritual aspect. And I must admit, we do have an individual that does a great job on the spiritual aspect. I call him a spiritual congruence therapist. Most of our individuals in depression, when they fill out their spiritual inventory, they have significant problems with God. Many of them don't even think God exists.